A female patient, 80 years old. Teeth 11 and 12 had fractured and the crowns had fallen off. Overall assessment, missing teeth on the right side, teeth 13, 21, 22, and 23 required extraction. In the area of 14, 15, and 16, there were crowns on implants placed approximately 20 years ago with cement-retained fixation. Treatment plan, a full-arch maxillary bridge. The main priority was creating a temporary construction, as immediate implant placement carried increased risk. The first step was removing the old crowns from the implants. To do this, the crowns were carefully perforated and unscrewed together with the abutments. This turned out to be the most labor-intensive step of the entire treatment. After that, the remaining teeth were extracted. Pro multi-units 0.5 millimeters were placed onto the existing implants, as the implants had a significant angulation and were partially exposed. Tooth 21 was slightly reduced to serve as support for the bridge. A temporary bridge was fabricated and placed to allow for healing and soft tissue formation. 3 months later, the second stage began. We placed 5 additional implants with PRO multi-units, extracted tooth 21, and fabricated a bridge for immediate loading. All work had to be completed within a short time frame. With PRO multi-units, this is convenient. Even with unfavorable screw access positions, the openings can be neatly sealed with flowable composite. The key is confidence in passive fit and strict timing. As a result, all work at this stage was completed within 1 day. I selected multi-units based on soft tissue height, but I prefer placing the tallest possible sleeves, conditions permitting. In this case, I used 3 heights, 3, 4, and 6 millimeters. The digital library allows precise selection of component size. Another 3 months later, the 6 PRO multi-units were replaced with CRESTFIT to improve aesthetics and overall appearance. The color coding of the multi-units is clearly visible in the photographs, and the replacement itself is simple and fast. When working with CRESTFIT, it is important to remember that the sharp angle of the trapezoid must face buccally. Now you can see the difference. The positioning of the screw access holes has changed. On the definitive bridge, they all emerge on the occlusal surface, making the construction more functional and aesthetic. We proceed with bonding the sleeves according to my protocol. A master sleeve is placed on the PRO multi-unit in the area of tooth 14. Its purpose is to serve as a reference point. During bridge try-in, it stabilizes the construction and prevents it from slipping. We bond the sleeves. The adhesive is stored in the refrigerator. This prolongs its working time and makes the process more controlled. Before use, we remove it from the refrigerator and apply it immediately. Each sleeve has only one correct orientation. The flat surface must always face the buccal side. The bridge is placed onto the master sleeve. We make slight lateral movements to allow the bridge to seat onto the multi-units and let the sleeves find their optimal position. Because the multi-units have low-profile cones, positioning is significantly simplified. The bridge easily finds its place. The construction is manually held in a stable position, after which the tightening begins. We prepare the hex drivers in advance with screws already mounted. This speeds up the process. Initial hand tightening is performed with the hex driver because it holds the screws more securely. Screws are tightened from the center outward. This sequence prevents internal stress and ensures passive seating of the bridge. Next, polymerization. After that, we remove the bridge to bond the master sleeve. Before bonding, a screw is placed into the master sleeve. Holding the sleeve by its plate, we apply adhesive and insert it horizontally into the bridge so the screw does not fall out. The screw access channel is extremely narrow, so the screw is held securely and does not fall out even when working at an angle. Because of this, any screwdriver can be used for tightening. The channel is positioned between the teeth, but due to its small diameter, the strength of the bridge is not compromised. We return the bridge into place. We tighten the bridge using the hex driver. Final torque of 35 Newton centimeters is applied with the trigon driver. This sequence prevents screw loss during work, ensuring safety and efficiency. After final polymerization, we seal the access openings. First, we insert polymer pins and fill the space with silicone-based material, which makes future removal easier. In a few weeks, I will remove the bridge, check the tissue adaptation, and perform minor polishing if needed. Therefore, it is important that I can easily access the screws. When reopening the channels, I gently remove a small amount of silicone material, lift the pin, and the screw access is immediately open. For larger access holes, I always pre-fit the pins. If they protrude, it is easier to trim them outside the mouth than inside. When the access is narrow, as in the region of tooth 14, I insert the polymer pin immediately. It fits securely and allows easy performance of all subsequent steps. Now a few words about the design of the bridge. This bridge was fabricated with wash-through spaces between the soft tissue and the prosthetic contour. I always prefer a small gap in the area of the multi-units so that an irrigator, interdental brush, or toothpick can pass freely for proper hygiene. This ensures healthy soft tissues. Some clinicians prefer bridges that closely contact the gingiva. This is a matter of preference and clinical experience. Therefore, this bridge was made exactly the way I wanted.